Hey everyone, I'm Aaron Potratz.
And I'm Nathan Hawkins.
We are the Shrink Think
Podcast,
Podcast.
baby.
Enjoy the show. Because, I don't know, when you talk, it just makes sense.
That's what I'm always doing.
Aye.
Oh no, you're the one that's on
Welcome
the camera.
everybody to the Shrink Think.
Everybody!
The Shrink Think Podcast.
All
That's
right.
us. All of us. Both of us.
We're both shrinking right before your very
and
eyes.
thinking. Shrinking and thinking.
No.
He's the shrink.
I think he's got it opposite.
I'm the
He's
Fink.
done it again.
F-I-N-K.
Oops-a-daisy. No, he's not.
Whatever. I can't believe how British we are. It's so crazy.
It's amazing. We're from different areas, though.
I know. They're actually watching and thinking, I can't believe it. It's like, I'm back home.
Back home in Europe, it's kind of, if you think about it,
The UK is
it's kind of broad.
sort of Europe, but it's a little different. Don't you know? I mean, you're from there.
I mean, that's what I'm trying to be from.
The shrink. I do the thinking. Okay, let's do this.
I am totally ready.
And start. Hey everyone, welcome to the Shrink Think Podcast. We are excited and riveted here to be with you. As always, did you know that medication can make a giant, extraordinary difference in your clinical care? Whether you are a therapist and you are dealing with a client or a couple, family, something like that, and there's a situation where somebody maybe needs medication and they're not on it, or whether you're a client and you're going to therapy and you're like, I don't know what's going wrong, or this seems to be not working, or something else is happening, right? I'm doing all the things, maybe I'm putting in all the work. It's like you're hitting the gym, cutting your calories, the numbers are all there, but you keep gaining weight kind of a thing. It's like, what's happening?
This is my life.
Nathan, go ahead and speak to this. You're on.
Yeah, so the medication thing. Okay.
Oh, we're doing the. I thought you were going to go back to the other. Okay,
Oh,
go.
no.
Yeah, we can skip over that.
A few different lines with this. One is if you need medication for something that's actually, and it's like, hey, if you had some medication for this, your life would probably be better.
And do you have some examples of that? Like when we're talking about medication, what are we talking about? Because maybe a lot of people out there don't know.
Yeah, okay. So we are probably more focused on behavior-related psychotropics. There are other medications that affect, like, for example, blood pressure medications. They have generally two flavors of those that are alpha blockers or beta blockers. Generally, they don't use alpha blockers anymore. They're old school, but they actually work really well for PTSD, actually. So, and that is not widely known. I'm telling you that, and you now have secret information, kind of. And then there's medications that kind of cross over and affect things from a side effect standpoint. So, which actually the beta blockers have a side effect, for example, of anti-anxiety. So, and they're not addictive. So sometimes doctors will want to say, hey, you should do something like this. You should use this because we don't want you addicted, and you can use it kind of whenever you want. Not totally whenever you want, but we're not here trying to prescribe to you. We're not telling you any kind of frequency to use anything. We're not saying, hey, you should use this at all. If you're hearing that, you might be on drugs.
Ooh, pun intended. He rounds the corner for home. Be safe.
Gotcha. Anyway, so the thing about it is, though, for therapists, we have these different educational forums, like meaning school and outside of school, to learn about psychopharmacology. And it's kind of interesting, right? Because we get to learn about it, but we're also kind of threatened to the point of ethical hell to not talk about it. Like, here's some information. Never share it. They'll think you're prescribing, and that's unethical. So a lot of younger therapists are scared at all get out to even talk about they'll be, maybe you should talk to your doctor about that. And oftentimes as a client, you're like, well, I don't know why you're bringing that up now. And the therapist at that point is going to be kind of nervous to even say why. And so I deal with younger therapists like, this looks like it could be a thing, but I really don't know entirely how to talk about it, because I don't want them to think, I don't want the doctor to think like, who told you this? And so I want to encourage some of the younger therapists to, like, you can walk into this. There's a way to have a conversation about this. The other side of that coin is some of the younger therapists don't take that class because most of the time it is a elective. It's not something that you have to take necessarily. And so, and then after you take it, it's like, well, what do you even do with it? So my point of this subject, because this is kind of my idea to bring this up, is to, number one, encourage the younger therapists and older therapists to actually take this pretty seriously, because it can have some dramatic effects in your client's life. And also to go ahead and to learn about it, because there is a lot you can learn from an intake form when somebody fills it out and then has these medications on there. You can learn a lot about what the medical world thinks about this person and what's going on for them and how they're trying to help.
So let's start there, because I think that's a great point. As therapists, just so the audience knows, for people who might not realize, there are like different levels of counselors, you could say, and people get this confused all the time. You have people who go to graduate school and get a master's degree. Those people are often counselors or social workers, depending on the kind of school they go to, and the license that they get, they're LPCs, LMHCs, LCPCs, those kinds of things, or they're social workers like LCSWs, kinds of thing. And then you have somebody who goes to a little bit more schooling and maybe gets a PsyD or a PhD, a doctorate degree. They get like a master's and then some. That is considered a psychologist. And those people often will do a lot of research. They write a dissertation paper to graduate. They've got a lot more education and training from that standpoint. But they still don't prescribe, right? The therapists and counselors in the first level and the psychologists in the next level don't prescribe. And then you have psychiatrists, who you tend to think of as like your lab coat donning, divvying out medication people. Those people go to medical school. Like they learn about psychology and they learn about psychopharmacology, which is your prescription medications, because psychiatrists, their goal is to help you with your mental health, right? So just general practicing doctors might know a lot about medication in general, like maybe general anxiety, general depression, general blood pressure, and hyperthyroidism and things like that. Because they're kind of general practitioners, right? But when you get into psychology, that's very different, because your mind and your body will kind of back and forth influence and impact what's going on with the medication. So there's like an extra variable that's going on that's very complicated. For example, people that have trauma or people who have like bipolar disorder, for example, different medications will affect different people differently depending on the level or the nature of those experiences or the severity of that mental illness. And so the different medications, you kind of need to monitor that something like a general practicing doctor isn't going to have as much knowledge and experience about the psychology of it and that variable that's influencing things. So all that's to say, we're talking about something that if you're a counselor that's out there, or even a psychologist, you might know a lot about medication because your clients are coming in and you're hearing all about it, and a lot of the people that you're working with are taking medication, but we're not the ones that are prescribing it, and we're not the ones that are medically managing it. We're just kind of hearing about it and then sending them off to people, somebody else to kind of deal with. And I think that's why we're talking about this, because we want you to understand the complexity of it, but also how important this is. Like, getting back on track here. So if I'm a counselor and I've got a client coming in and I'm reading their chart and it looks like they're taking these medications, I might be thinking, oh wow, you've got a lot of stuff going on, but what does any of that mean?
Right. And to say one more thing that I think is just interesting, that you were kind of on your line, Aaron, about like the distinguishing differences. For a psychiatrist, just for perspective, they are going through the exact same school medically, right? Like Aaron was saying. What happens is at the same point where the doctors make a decision to either go just leave and become a family doctor, or they want to become a surgeon, like that whole thing. That same point of decision making is where is where a lot of these people will become psychiatrists.
It's like they go into the specialty field, right? Psychiatry, surgery, or
whatever
else.
Hand doctor. Anyway.
Yeah.
So because of that, that kind of lends itself to why there is a shortage of psychiatrists in the United States, because financially you're going to make way more money as a surgeon than you are as a psychiatrist on average. But so that's kind of a side note, but it kind of speaks to the supply demand issue. So, and if you go to your psychiatrist, if you have one, the funny thing about it is you can actually get treated for your cold while you're there at the same time, because they just do it all, right? So at any rate, you're looking at an intake, moving back, right? And a lot of times, if medications kind of overwhelm you, meaning like, oh my gosh, it's so complicated, then you probably just skim past that. I would imagine you look at the medication list because you know you have to have it on your intake, but you probably go, okay, they want to come into counseling because they don't, and there's Medicam. Let's see what else.
They're taking Wellbutrin and Effexor, and okay, wow. And maybe like a thyroid medication, don't know what that is, but you're taking it. Okay.
Yeah, so let's say that someone comes in and they've been told that their partner thinks they're depressed, they need to come in and work on this, and it really bothers them, and so they come in and they present to you like kind of a lump. They're sitting there, not really. They're what's called anergic, which means without any kind of energy. Their way that their face looks is like kind of flat, meaning like they don't really have very many expressions at all.
Eeyore might kind of fit this.
Yeah, so you look at them, their presentation is that, yeah, they're depressed. So you kind of would expect like, I wonder if they're already on an antidepressant, So you look back on their chart and you find out, oh, no, they're not on an antidepressant. Okay, so maybe nobody's even dealt with this before, right? But then you see gabapentin or, Seroquel or something like that. And you're like, and if you understand some psychopharmacology, you're looking at what's called an antipsychotic. So they are on an antipsychotic. Okay, well, one of the side effects of antipsychotics is exactly the presentation of this person that now looks like a lump. That's literally what the drug does. So they have been misdiagnosed by their partner as having depression. Now there might still be depression. That's the fun thing. Now, as a counselor, the way that I would interact with that is to try to understand the history of their experience, and how it was that they ended up on this medication. Because maybe before they've always been depressed and this medication is making it worse. Or maybe they were fine and they've been trying to tell their partner that this is why it is, and their partner won't listen, and maybe you could send them back to their doctor after conversing with them to say, like, I don't know if your doctor can lower the dose. Did your doctor even know that you were depressed before? Like, I mean, does he know or she know like this effect that's having? They probably do. And this is the thing with general practitioners, some of them will prescribe these type of medications, and some of them won't. Some of them will be like, nope, I'm sending you to a psychiatrist. I'm not comfortable doing it.
Like out of my scope, or that's like kind of above my head kind of a thing.
Right.
Because there are, like we were saying, that's why I explained that. There are so many complexities to that, and they know that, and they're like, I'm not even going to dabble in that because that could actually make things worse.
So, and therein lies some of this, right? So you find out that, oh, this is just a GP, a general practitioner. That's fine, but it may be that the general practitioner understands some side effects, but they might not realize, because they might not do this that often. They might not realize like how much it's actually affecting you, that it actually bothers you. And so you go back in, and so it's important to go back in.
And that's the other thing too. I'll kind of put this infuse this to the episode as well. A lot of people, when they go to the doctor, they might explain like, oh yeah, it's not bad, or it's this or that, or whatever. And then the doctor responds and like nothing's really getting better. And then you go to the therapist and you explain that. And the therapist is like, wow, why didn't your doctor, like, why are they responding this way? Come to find out, a lot of times if you're a client listening to this, you might not actually be representing your experience clearly enough and directly enough for the doctor who's got people in and out, very quickly. And so you got to put it in terms. I've had people like change this, and all of a sudden the doctor immediately responds differently. They will say like, oh, it's not bad, but it's keeping me from being able to function. So it's like a 7 out of 10. And the doctor's like, oh, whoa, okay. Well, we need to like do some tests, or we need to like change the dosage. And before they were saying, well, it's not bad, but I'm having trouble, like kind of explaining. And it's not like in certain terms that are concrete enough that communicate the effect of the, damage, or the effect of the drug well enough so that the doctor understands. So just side note, if you're taking this, be aware of like if you're communicating with your doctor, be really specific and clear about how it's affecting your functioning.
Yeah, the other thing out there is you can't totally trust Google with a lot of this stuff. Surprise! So,
shocker.
So like, or WebMD or whatever. I mean, there are resources in general, but I'll give you an example that I kind of already spoke to. So take a beta blocker. Just taking the general big picture of beta blocker. I'm trying to think of it. Propranolol would be one. So singers will often take those type of medications, and they're not taking them because they have a blood pressure problem. They're taking them because it won't affect their physiology and their voice when they sing, but they might have stage fright and some anxiety that they get in their head about, and they don't really want to be witnessed when they sing, and so they get kind of scared, which changes their voice because it moves things around. But the side effect of taking a beta blocker is to calm your heart down, and so because your heart is more calm, you are just simply less erratic. It's just affecting your physiology, right? So then you don't experience that anxiety, but you can still sing just fine. So they only have it because they want to use it, and the doctors know this. And so you can sometimes, if you're a therapist, look at the intake and be like, why are you're only like 28. Why are you on a blood pressure? Like, what is going on, bro? You seem like you're fit. You know what's happening. It's worth a question, right? Because now they might be coming into you for something having nothing to do with any kind of anxiety related thing at all. And they want to help with their family and blah, blah, blah. And you look at that and you ask them and they say, oh yeah, that's because I sing. Okay, well, that same physiology that you have also can show up in other places. It doesn't mean you need to take medication more, but it is a window into how you think and how you work, and also how other people could be experiencing you. Well, I just thought I just use it because it's only this, well, you've never experienced that feeling ever before in your life, only when you stand, up there. Well, no, so all of a sudden now it's a totally different conversation, but you're not treating them with medication. But this is why it's important to kind of get in there and understand. You don't need to know like all these interactions with things. You're right, therapist. You don't need to know that. That's totally true. But being a good advocate for yourself is a big deal. Years ago, I went to a psychopharmacology thing.
Like the 1700s.
Yeah, it was, I rode in on a dinosaur in the 1700s. Yeah. It's just an oil slick
he
now.
He sucks at math.
Right.
Anyway.
So, the prescriber that was teaching us, running the class, made the comment. He said, look, he goes, you guys are not prescribers. But he goes, I want to give you an example. He said, take the thyroid, right? Somebody measures your TSH level. And he goes, it's TSH. He goes, for all you prescribers out there, I'm also pitching this to you because you're also not paying attention. And so, of course, as the young guy, I was like, oh, I want to learn this, right? So, and I haven't forgot it. A normal TSH is considered in the medical field between 1.0 and about 4.0. So if you come back like at a 2, they're going to be like, oh, you're fine. If you come back at a 1.5, you're fine. What this prescriber was saying is, if your patient or client is depressed, and then their TSH comes back at a 1.5 or 2, or anything below 2, anything between 1 and 2, then probably they need a little bit of thyroid, even though you think it's normal. He goes, I've seen people literally wake up out of a fog just because it was not their normal, So it's just fun facts like that you can, and I've actually told people that before, where I'm like, hey, this is what I learned. Maybe you should ask your doctor about it. Like, that doesn't mean I'm telling them they should do it. I'm just trying to help on the outside of what I learned, is like sharing knowledge. And they're not going to get that on Google, side note. That's going to be down some rabbit hole on like Reddit that's out there. Anyway, I don't know if you have anything to add, Aaron. I've talked a lot.
No, I think it's just, we wanted you to understand just how significant a role medication can play. We're not necessarily saying that if you're a counselor that you need to be suggesting medication for people.
No, we're not saying that.
Or not suggesting it. We're not even commenting on whether or not you should. We're just simply saying that when medication is present, or when it needs to be, like in this like thyroid situation, for example, when it's presenting itself in your client, or if you're the client and it's part of your life, then it's playing a role, it's a factor and a variable in your care, and it's something that ought to really be considered, because it is affecting your physiology. And at least getting some information, from the client about it, or from the doctor about it, or doing a little research together on, okay, what is this medication that you're taking and how is it affecting things, so that together we understand what's like the full picture of what's going on. Because if I try to work with something and change something as a therapist with a client who's got some of this stuff going on, and I'm not taking that into consideration, I could be working against myself at times. And that's going to be really frustrating for both.
Home here, that of how long a person's been on some of this stuff, because sometimes it's not doing what it's supposed to do, and that doesn't, because they're presenting with all the problems that this thing is supposed to make not happen. It's like, okay, well, you might want to go back to the drawing board. And they think, oftentimes client, you think, well, it doesn't matter, they've already done this, it's doing the best it can. If all your family members are the same, they still do share your last name type of thing. They
dark hair when everybody else has blonde hair, like it still happens.
So just because one is not working that well doesn't mean another one won't. And it doesn't necessarily mean you should even be on the medication in the first place, but just some encouraging words from us at Shrink Think. Have a great day. Had to jump in on you because I was like, bro's gonna try it. Bro's gonna happen.
Got to keep you on your toes. Get you out of your routines.